Hi, good morning. This is Dr. Harish from Atlanta on the east coast of United States. I'm a board certified nephrologist. I'm going to be talking about diabetic nephropathy on this Health DNA platform. They're doing a wonderful job by creating awareness, educating the people across Northeast India and other parts. And it's a privilege to be on this platform talking about diabetic kidney disease. Diabetic kidney disease, the pathogenesis type 1 and type 2 is beyond the scope. Let's go straight into the manifestations of diabetic nephropathy, how this occurs, the time frame, and the progression to end-stage kidney disease. Initially, the people need to have an awareness of the disease process as such. Diabetes is a metabolic issue. Some people call it genetic disease. Now there's some evidence that it's autoimmune disease. But the time frame from the onset of both types, type 1 and type 2, it takes about 10 years or more for kidney disease to happen. And the incidence of diabetes varies in different populations. It's in the range of 20 to 40%, but some populations like the African American, the Hispanics and native Indians here in the United States, they have a higher incidence. So in India, basically, we can say it's about 20 to 40% incidence, but not everyone with diabetes will have diabetic kidney disease. So you have to be screened. There should be an awareness that diabetic patients, once diabetes is diagnosed, or if they are borderline diabetes, if there is a family history, and if you have a tendency, you need to be screened for kidney disease. If you don't have protein in the urine at the time of diagnosis, your primary doctor or your nephrologist has to screen you once or twice a year until there is frank proteinuria. Before that, there is microalbuminuria. Albumin is the blood protein that escapes into the urine, and that is a manifestation of diabetic kidney disease. High blood pressure with protein in the urine and the creatinine going up, these are all hallmarks of early diabetic kidney disease. But there is some evidence that you need not have protein in the urine. About 25% of the patients with presumed diabetic kidney disease do not have protein in the urine. They could have other pathologies going on, and generally we don't do a kidney biopsy on patients with established diabetic kidney disease, proteinuria, history, and almost 100% of the time you see characteristic changes in the kidneys. So pre-diabetic stage, you have to create awareness, and people have to be tested, screened, diet, weight management, and then screening for kidney disease, like I had mentioned earlier, is a very essential component of management of diabetic nephropathy. Once you find protein in the urine, microalbumin in the urine, creatinine goes up, blood pressure is high, kidney diseases, any chronic kidney disease is classified in stages like stage 1 to 5. And it progresses. Diabetic nephropathy is a progressive disease. All we can do is to slow down progression. You cannot prevent or halt diabetic nephropathy with the current technology and testing that is available. So controlling blood pressure, controlling the weight, controlling protein in the urine, and managing the electrolytes and fluid balance, because as kidney disease progresses, people have metabolic acidosis, which makes potassium go up, and kidney has decreased ability to excrete electrolytes like sodium, potassium, and water, and they develop swelling and edema and uremic symptoms. We don't know what causes uremia. Symptoms are basically, when we talk to patients, we tell them, advanced kidney disease, you need to look out for loss of appetite, loss of taste, just apathy, fatigue, feeling sleepy all the time, loss of weight, swelling in the ankles, high blood pressure. All these things prompt immediate attention, and slowly it progresses to end-stage kidney disease, where people need dialysis. But there are several things happening from stage 1 to stage 5. Stage 1 is defined as kidney function more than 90%, and you have some hypertension, some protein in the urine that can be managed. And at every stage, you can slow down the progression of kidney disease. And as kidney disease progresses, there are, besides hypertension and protein in the urine and kidney dysfunction, there are other manifestations like vitamin D deficiency occurs, because kidney is the organ where vitamin D is activated, hydroxylated, and only then it works on the parathyroid glands, on the bones, and then the intestine, regulates phosphorus and calcium metabolism. So low calcium because of vitamin D lack increases parathyroid hormone levels, and parathyroid glands are 4 glands in the neck, and they cause what is called mineral bone disease, MBD, of chronic kidney disease, which is not a very pleasant thing. It's a spectrum of bone disease, crippling bone disease. Cysts develop in the bones become soft and fragile. And these are all things we can control, so bone disease we can absolutely control. Even if the chronic kidney disease progresses, we can control this with regular measurement of calcium, phosphorus, and parathyroid hormone levels, with supplementation of vitamin D. Management of acidosis, hydrogen ions, that's the acid which is not excreted well by failing kidneys, causes acidosis, and it causes bone resorption. Bones become thin, soft, potassium levels go up, and then people have uremic symptoms and acidosis. Those are all towards the end of the spectrum in stage 4, stage 5. And this can be promptly managed with sodium bicarbonate supplementation, and it's even known to slow down the progression of end-stage, advanced stage chronic kidney disease to end-stage kidney disease needing dialysis. And another most important aspect is anemia. Erythropoietin is a hormone, just like insulin. Erythropoietin is a hormone that's made in the kidneys, and it stimulates the bone marrow to produce red cells. Whenever the oxygen saturation drops, erythropoietin is secreted in the kidneys, and then it stimulates the bone marrow to produce red cells, which carries the oxygen to different parts of the body. So in advanced kidney disease, people become anemic, and even in 4th stage, 5th stage, or sometimes even in the 3rd stage, there is disproportionate anemia, and people may need erythropoietin or erythropoietin stimulating agents. Newer agents, synthetic agents are available that can stimulate the bone marrow. Then we check hemoglobin levels every week or every 2 weeks, depending on how severe anemia is, and they get these shots, injections, and it helps to maintain red blood cell level. So kidney disease is progressive. Diabetic nephropathy is progressive, and it can be slowed down with intervention and active treatments, which I had outlined. And once end-stage kidney disease happens, they are on dialysis. And very important aspect between dialysis and chronic kidney disease progression is people start having lower glucose levels, because insulin is excreted in the urine, and when kidney function decreases, the insulin half-life increases, which means what is insulin available for 6 hours will stay in the system for 12 hours, 24 hours, even 48 hours, and people start having hypoglycemia. So it's the nephrologist who identifies this and prompts decrease in level of oral anti-diabetic agents, and insulin levels insulin dosage and all that stuff, and that's very important because low glucose is more dangerous than high glucose in advanced kidney disease. And once people progress to end-stage kidney disease, they're on dialysis, and we have to be cautious about using glucose and glucose-containing fluids when we do peritoneal dialysis. It's a different type of dialysis where blood is not involved, and with a small catheter in the abdomen, we exchange dextrose or glucose like fluids, and that does dialysis without having to put a needle in the access or having to place a catheter. So then management of end-stage kidney disease is like any other kidney disease from various other causes. But the bottom line is diabetes is increasing. India is going to be like a diabetic capital in the world, and incidence of kidney disease 20% or even 40% is going to cause a lot of issues, and we can nip it in the bud. We can slow down, identify patients who are prone for diabetes with family history, with obesity, with metabolic syndrome, physical inactivity, diet control, salt control, controlling blood pressure. This can be done by primary care doctors, and then HealthDNA is doing a good job by promoting this awareness and exercise, diet, and all these things. Even for kids, it is most important to be aware before they hit the 30 or 40 year age, when they are prone for all kinds of diseases, when these genes start expressing a period. And once the disease is diagnosed, it's early referral to a nephrologist is very, very important. Managing, like I said, protein in the urine, mineral bone disease, secondary hyperparathyroidism, and then managing acidosis, managing hypertension. Nephrologists are also specialists in hypertension, so can definitely add a lot more management of chronic kidney disease. And there are a lot of things happening in angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and now aldosterone antagonists. They also help not only better control of blood pressure, but also they help in decreasing proteinuria in diabetic kidney disease. So these are all things which we can intervene, slow down progression. Adding sodium bicarbonate to stage 4, stage 5, and measuring CO2 levels is very important. So this can be done very effectively, and we can prevent progression of disease. One word about transplantation. Diabetic kidney disease can occur in a transplant kidney. So, same holds good, when the person is transplanted with a new kidney, as they still have diabetes, and insulin half-life decreases because there's a normal kidney, and they start having hyperglycemia, and they're treated with steroids, which increase glucose levels. All this have to be effectively managed, and diabetic nephropathy can happen in the transplant kidney as well, in the same time frame. After 10 years, after 8 years, people can still develop diabetic nephropathy in transplanted kidney. So it's very important. It's a team effort, dietitian, primary care doctors, nephrologists, the transplant team. All of them have to be involved to slow down progression, recognizing complications, recognizing the disease itself, creating awareness. And the fundamental thing is early intervention, knowledge about the disease, and then diet, exercise, and prompt treatment, follow-up, and create a little bit of good fear in the patient's mind, so that they know what is happening. And doctors should be more patient, explaining in detail. I take about 45 minutes to an hour when the new patient comes in with just protein in the urine, and then explain everything to them. When they walk out, they know about the kidney disease, and when you educate the patients, they're going to be better patients. It makes your job easier. So spend a lot of time in telling them about the disease, telling them about simple things like lifestyle modifications, and then diet, exercise, being aware, and spread the good news to the family members and friends, and being aware of protein in the urine and high blood pressure management. Tell them all about the latest things in blood pressure control, diabetic control. Three things which slow down progression of diabetic nephropathy: the hemoglobin A1C should be targeted to less than 7. Hypertension control, blood pressure management should be like 130 over 80 or less in diabetic patients with kidney disease. And protein in the urine, like of course, if it is in the microalbumin stage, it's very good. If there is frank proteinuria more than 300 milligrams per 24 hours, that has to be reduced to 500 or less. So these three parameters, they slow down progression of kidney disease. With this, I'll conclude my short talk, and then I'll take questions from here. Thank you so much for having me here. It's a pleasure.